Well, welcome today to another conversation. And I have with me, all the way from the UK, and our time differences, we've managed to get it together, Dr. Marie Polley, who's joined us to talk about social prescribing. She's the co-founder of the Social Prescribing Network, which we'll talk about a little later. But welcome, Marie, and thank you for joining us.
Hi, Kathie, and thank you so much for having me on these conversations. It's great to be with you.
So tell us a little bit about your background, because I read your bio and it's a fascinating journey you've had to where you are now.
So I started off with a degree in biomedical science and looking at how you basically run the laboratories in hospitals and stuff like that. And I got offered a PhD when I finished my degree. So I did a PhD and I looked at DNA, which is, I always love talking about DNA. And I looked at how DNA gets damaged by chromium in lung cancer. So we were looking at how that affects how cells replicate and did lots of molecular biology. I went on to postdoc at Imperial College in the cancer cell biology department, and we were looking at the effects of tamoxifen resistance and things like that and the signaling mechanisms. So some of the signaling mechanisms that are established now were the ones we were establishing at the time. But actually, whilst I was training during my PhD, I also trained as a Reiki practitioner, which I got a lot of stick for. Something like Reiki is not really respected in a biomedical profession, but Reiki is quite a profound complementary therapy because people don't have to talk about what it is that's really troubling them, and you're not diagnosing, you're supporting them. So I saw some really interesting differences that happen to people that probably wouldn't have been even put in a textbook if I was just sticking with a biomedical paradigm. And it really got me thinking that there's so much our bodies can do and there's so much we can do, and are we just dismissing aspects that we could take control of ourselves? And then I went on a journey of working in a kind of quite a dichotomy of having this scientific side and reductionist and statistics and standard errors, and all the medicine professionals and everyone will know what it's like when you want to look at your p-values. But then I was actually this very holistic, uncategorical side of just understanding what's important to people. So I worked in integrative oncology and personalised care, looking particularly at what happens with people who are on a cancer journey when you support them with complementary medicine and with biomedicine. So having all the standard treatments that they'd be offered on the NHS, but supporting the psychology, the nutrition, using things like reflexology, nutritional therapy, Western herbal medicine, counselling and support, and looking at the whole person. And did quite a lot of research on how to capture what concerns a person, how it affects their well-being. And actually the things that people with cancer would talk about is actually, yes, there's the hospital treatment and the diagnosis and the prognosis, but there's the existential crisis that comes from finding out you might die earlier than you expect, and the psychological issues and the fear, and what's my purpose and meaning in life? Why am I here? Why am I still in this marriage I don't like? Why am I living where I don't want to live? You know, and actually allowing people to do something that they can get some control back in their life, you know, about how you look after yourself and that whole area of self-care and decision making. So when we started to research people's concerns, actually, you know, probably 75% of the concerns were actually what else is happening in the life. But actually in the research, that's not documented. You ask about stuff that's related to the disease and the symptoms and maybe some activities of daily living. And we found that, you know, rarely did anyone ask about the spiritual side of things. Yet people would say, my main concern is, you know, I don't know what my purpose in life is anymore. So there's a whole aspect of, you know, the research and medicine's lost that conversation around spirituality, purpose and meaning, and the importance of somebody's whole well-being being affected by all these different issues. Or it might be their work setup, or it might be relationships, and that we did some really interesting research on the relationship between the carers and the person with cancer, and the carers being concerned about the person with cancer and vice versa, and those concerns affecting each other's health, and bringing those people together in those open, honest conversations. So did that for quite a while, and worked on an outcome measure yourself concerns and wellbeing, which is used sort of around the world, and we have a company that licenses that now. And I worked as a senior lecturer at the University of Westminster, so we were training students that are either doing biochemistry, biomedicine and all of that, but also all the complementary medicines. So I taught them a lot about the pathology and physiology and statistics and research methods, and ran a research group in outcome measures. And I did that for about 15 years. And towards the end of my time at University of Westminster, I set up a social prescribing network, which is one of these things where somebody came and said, we'd like to do a study with some GPs, and we want to look at the role of a person kind of supporting people with diabetes and pre-diabetes. At the time, pre-diabetes hadn't been a term that was coined by our health service. It was just as this whole recognition that you could intervene before someone actually had blood sugar levels that would put them into a diagnosis of diabetes, and actually maybe you could turn it around, and is there a prevention here? And this project just kept knocking on my door, and I kept turning it down because I was like, well, actually I don't really, I know a lot about the world of cancer, but I am quite I have my own faith. I'm a lay leader of worship in a church, and you just have this moment where you just have to say, okay, after the third kind of knock on the door. I don't really know. I don't know why. Anyway, so I took this project on. We did an evaluation, and we showed that people in this GP practice, if the GPs recognised they needed support and said, okay, you've either got type 2 diabetes or you're on that road to and you're at risk, they referred them to a person that we call a link worker. And that person sat with them and said, so what's going on then? And they spoke in lay language. And actually you find people had all sorts of things going on, but mainly they didn't understand how to find out what it was they're eating. So they couldn't read food labels. And there's about 20 ways of saying sugar on a food label. And unless you've got a degree in biochemistry, you wouldn't know that. And nobody tells people, and the industry is very secretive about that. So when people learn to read a food label that basically says sugar, sugar, fat, sugar, a couple of other things, sugar, they would choose to eat differently. And they didn't realize that if you walked at a pace that your heart rate got going, that you needed to do that to actually burn some calories off. So people ended up walking further and faster. Someone actually came and said, I'm really worried, I've got a lump on the back of my leg, and it turned out to be a calf muscle developing. So just that people's understanding of how to do their own self-care and have a regime that was slightly healthier. And we saw a third of people with pre-diabetes go back to normal, and a third of people with type 2 diabetes, their blood sugar levels then went back into the at-risk rather than type 2. So we gave evidence to the diabetes prevention panel as they were setting up the schemes in the UK. And my co-chair, Michael Dixon, is well connected into the government, and we were briefing the Secretary of State for Health every sort of 3 to 6 months, which is a very surreal moment in your life when you have to send briefing notes to the government. And then actually that started rumbling around, and I just applied for a grant, and we started to know that there were a few other GP practices doing things differently. And so I led a grant to the Wellcome Trust, and it was just for £40,000. And we wanted to look at health creation rather than just maintaining disease. And we got some money and we set up a network. And the idea of setting up a social prescribing network was actually people need more than just medicine. They need other things sometimes. They don't need medicine, but sometimes they need medicine and something else. And depending on what your idea of medicine is, it's become very pharmaceutical. Prescription of drugs. If you look into the 1960s, it was not that. You had, and it might be very different in Australia But in our country now, it's primary care is a GP sat in an office. Well, it was until the pandemic, but sat in an office having a 6-7 minute conversation. It's quite transactional. You know, there's no time for anybody to get any other further information, and very few home visits are done in comparison to what would have happened. The doctor would have known the community a lot more. You know, we don't have bloodline community so much. You know, everybody's moved around. I moved away from home and stayed away, and so our community structures changed, and I don't think it's as strong as it used to be. So the whole of medicine's changed, and I think we're shifting a bit now back to this actually relational point. So we
So
set
if you
the network up. Go on.
so
I was
if
going to
you
say
were
we set
to
the
sorry, I don't mean to talk over you. If you were to say in one sentence what social prescribing is, then from the network, what would you say it is?
social prescribing is supporting a person with what it is they need, not necessarily medical or pharmaceutical, but listening, unpacking, non-judgmental, compassionate, somebody coming alongside a person in their time of need, helping them understand what the priorities are and helping them work out the solution to moving forwards. And that solution is usually connecting them to organisations that already exist in the third sector or the housing or employment and things like that. So it's an architecture. It's not an intervention, it's an architecture of bringing people together that are identifying people in need. So health professionals, allied health professionals, fire service, police, ambulance, adult social care, people working with young people, and saying, look, refer this person to a link worker. They're not clinical, but they know how to have a conversation, how to listen, they're compassionate. They're going to just come alongside that person and establish a relationship, and they're going to talk in lay language and they're going to listen, and then they're going to work with that person and say, right, actually I think we can, there's an organization that's really good at supporting this thing, and let's, and they work with a person over a period of time. It's not a referral pass on, I'm not going to see you again. It might be 3 conversations before the person's ready to go to an organization, and they facilitate that transition. You don't say, right, go, because who's going to go on their own? You go with them. So it's a whole structure of getting people to the right place for the right support.
Okay, so the Social Prescribing Network is about looking at the evidence for that and helping set up the architecture in the UK.
Yeah, so the network in its basic form was there. It was just, if you're interested in this thing, just sign up for a newsletter, and we just hear what's going on the ground. We connect people, because I just get really wound up if I know that different people are trying to do the same thing at the same time, because duplication is just so inefficient. So it's about getting rid of duplication. In the early days, the network actually really gathered what was happening on the ground and fed that back up to the government and NHS England and helped design this architecture. So it was a ground up movement. The government and NHS rolled it out a couple of years ago across the whole of England, and it's just going into policy in Ireland now as well. And so since then, we've been supporting the rollout. We have regional leads, but now it's gone to a whole new level, Kathie. There's a National Academy for Social Prescribing was announced by our Secretary of State for Health, and that's sort of really got going in the last year. They're looking at how to bring the community organisations together. They've been bringing, the different government sectors together. So the Department of Work and Pensions and Culture and Sport and all of that, because we're talking about, people need support in all areas of their life. So it's about, how do we now sustain this as just an architecture that, anybody should be able to go to a GP in England now, and if they ask for social prescribing, they should get to a link worker and they're going to support them. So the network just allows people to find out what's going on in their area, and we work with people internationally now. This is sort of spread out to quite a lot of countries. So we are a very, very informal network, no fees, there's no criteria. I really believed that if you set a criteria and a fee, you create a boundary. So what let's just try doing something where you don't do the normal, you've got to have a subscription, you've got to have this, you've got to be incorporated. What happens if we just said, come and talk, come and get together? And it was an exponential takeoff for 3 years. It just went ballistic because people were given permission to connect with compassionate people who wanted to do something different outside of this very fixed system we work in.
Oh, wow. So can you give me an example of somebody being prescribed social,
Yeah. So maybe I could give you a couple of different scenarios.
Yeah.
So you could take somebody who's in a aged population who might be in their 70s, 80s now, and so a typical example would be someone like a lady who lived at home with her husband. Her husband was basically housebound and then went to bedbound, and he had a chronic heart condition. So it was getting worse, and she's trying to cope on her own. She's basically acting as the carer, although she wasn't getting the benefits for being a carer, like the financial carers allowance we provide as a government. And she'd become very isolated because she couldn't go out anymore, and needed help. And they lived in a house that was a bit of a fire trap, really old, lived there all their lives sort of thing. She doesn't know who to ask to do stuff, doesn't know where to go. So I think it was a GP that had done a home visit to the gentleman, who looked around, as you do when you do home visits. You can look around and you can clock so many more things, and then organised for a link worker from the social prescribing scheme in that area to visit. And at the time they could do home visits, so they went over and they spent some time. They recognised not only did they need to support the gentleman who was housebound, but they needed to support his wife. They were, the wife and the gentleman, they weren't able to connect technology wise. So a lot of the applications to get allowance and benefits are complicated and done online. So that got sorted out for them. They supported them through that and actually sat and did the applications. But they also recognised there were issues with the house, and our fire service in England will do a safe and well visit. So a fireman comes out, they check the security of the house, they refitted the fire alarms because the fire alarms had not been working. And the lady didn't know how to change them, where to go for help. So the fire service came in and sorted all of that out quite quickly. And then we had the pandemic. And then during the pandemic, this couple tried to register for the vulnerable shielding list, and they couldn't get it right on the telephone, and they kept getting cut off, and they kept putting the wrong numbers in. But they knew the social prescribing link workers checked in. I mean, across the country, they did this most tremendous response. They already knew who a lot of vulnerable people were. They immediately checked in. They then facilitated them getting onto the shielding vulnerable list so they could get their shopping delivered. And then, sadly, during the pandemic, the gentleman passed away. And again, the social prescribing service was there to support the widow that was left behind, and they supported her getting paperwork and things like that. They kept checking in with her because they couldn't go and visit, and she's sort of come out the other end, but her house hasn't burnt down. She's had anything done in the house she needed to be secure. They were both supported with the essentials that they needed, and that's happening a lot during lockdown. Then you could have somebody who might have really completely different age group, some really serious mental health conditions, and social prescribing is not there as a mental health provider, but it's about recognizing someone needs support. So they may then be referred back to medicine to get some fast mental health support. But often what you have is low-lying mental health situations. But you might have a person who, another example, person who actually is an adult, a high-functioning autistic adult, and they had episodes in their life where they basically had a breakdown every sort of so many years, and they'd got a family and they'd got businesses, and they just got to the end of their tether one day and didn't know what was going on, and they'd lost track of correspondence that was coming into it. Everything had just piled up, and again, link worker came in And in fact, this person didn't want help at first, and the link worker just gently tried over a little bit of time. And they had a conversation, you know, when that opportunity arose, they had the conversation and they sat with this person and they looked at all the things that had got out of control. So it could be correspondence from all sorts of agencies, employers, everything. They went through the paperwork with this person, they organised the paperwork, they prioritised everything that needed actioning, and they put it in a box and they said, you take one thing out a day and just deal with that. And then they supported this person to get to an organisation where they could do some singing and be part of a community choir. But actually there were lots of questions that the person had. They were like, but how am I going to get there, and where do I park, and what happens if there's no parking spaces, and what happens when I open the door to that place, and what if they don't like me, do they know I'm coming? You know, that huge anxiety about doing something different. And actually, so the link workers said, right, we've got people that will go with you and they will accompany you for the first few times. And once you've met everyone and you know what you're doing, and you know what the structure is, and you feel okay, then they stand back. And this person did get to the choir and they loved it, and it made a huge difference. They connected. You know, singing is so powerful, and music. So that connecting to that creativity, but also doing the actual practical stuff around the administration in their life. And that person's really gone on to flourish, and they're back running their own business. So we hear about people that they get that support, they're in a very vulnerable, dark place, that someone comes along and gives them some hope. They come along and say, we'll do this together. And for the first time, they feel they're being listened to because there's an hour. They're unpacking all sorts of things. They're prioritizing and someone's helping them with this decision making. So it's not saying, oh, we think we know what's best for you. It's let's work with what you feel is the priority, and then helping them get connected and walking alongside them until they don't need that support, so to speak. And it could be for physical activity and getting out into nature. It could be around stopping smoking and sort of what the areas of modifiable risk factors and self-care. It could be helping people get to a course that's going to help them get a bit more training so that they're then more eligible to get a job. It could be volunteering to build up the confidence of interacting with people and build up some skills, but whilst maybe doing that outside and getting physical activity. But most important of all in all of that is the connecting and not being isolated, and connecting with people who want to hear you. They want to hear about you. And you go to a group doing something you like, you're going to meet people with a shared idea of what brings them joy as well. And a lot of people then, as you work through this, it must be something you hear a lot. People will turn back to us and say, every Thursday I've got a reason to get out of bed because I know I'm going to this group and these people like to see me there, and I feel valued and I've got a purpose. And it comes often quite deeply down to people understanding that they're not sure what their purpose is in life at the moment. So on a very deep level, this for some people is quite a spiritual journey. For others, it's something quite it's quite open and shut. But for a lot of people, I hear this again, what I heard in my previous research around supporting people's well-being if on the cancer journey. It's about the purpose and meaning, and doing something that brings them some purpose and meaning, and doing it with people that value them. And it's that hope and that love. You know, these are very basic tenets in our life, aren't they, that make us feel happier. So that's you know, kind of what happens on a daily basis across the whole of this country.
How beautiful. So tell me, the link worker, as you call them, are they social workers? Because they've obviously got to be really deeply connected to networks and communities to have a shopping bag of resources.
Yeah, no, they're not social workers. So they do the a lot of them have backgrounds in some of the sectors of nursing and social work and things like that, but they only do the connecting with people, building the relationship. So a social worker in this country, when they do a first meeting with someone, they've got actually a huge framework of things they go through, and they're looking at all sorts of things, how this person's living and what they can do on their own. There is one section of that framework which is really about connecting to organizations in the community and that person's sort of friendship circle and things like that. So we do have, some schemes have referrals from social workers that will say, can you help this person spend more time, help them connect, and that side. So that works well. So the link workers, I think, are they're really the middle cog of a very complex system that we have in this country. So the idea is that everyone, finds someone and refers them to the link worker, but the link worker, they're not medically trained, they're not clinically trained, so they're not doing clinical conversations. They are there to understand and explore what a person's unmet needs are and what the concerns are, and help them then connect with what is already available, and make sure that the organisations in the community are being utilised. And part of the role of a link worker is to reach out to the organisations and have those relationships with the third sector to understand what is available locally. And where you've got big teams of link workers in some of the broker organisations in the community, they may identify the need for a new group, and say, actually, there's a certain need that there isn't anything to meet it, and they can support something being set up. So they're not social workers, they're not physios, they're not occupational therapists, they're not medical, but they
Human beings.
They're human beings.
Isn't
Yes,
that lovely?
they can listen. Yeah. And some people will go and they will say to a link worker, this is the first time I've ever told anybody this, particularly if it's to do with abusive pasts and stuff that's happened to them. And sometimes it could be 2 or 3 conversations before you actually have peeled away the layers that reveal actually what is happening. And we have this now developing for children and young people, and we've just published a framework of how to set this up for children and young people. And it's very different for children and young people. They've never experienced doing certain things in their life, so there's a certain amount of coaching and helping their confidence, and still they're needing to go with them to connect to things. But children and young people have when we sort of researched to do the framework, they would say, what I like about the link worker is they're not asking me lots of questions to then decide if I've got a mental health condition. So there isn't that judgment, and then some saying, well, you have got a condition or you haven't because you don't meet a criteria. They're saying they take us for where we are at face value, and if I say I'm not feeling great, they believe me. Whereas, when you're waiting for a clinical decision, is what's wrong with you, is there something wrong with you or not, that's really, really different to someone just saying, okay, I appreciate you not having a great day, let's look at what we can do together then, and let's see how we can support you. So actually, we're finding that where we've got step-up psychological services for children and young people, which are absolutely overwhelmed and kind of overwhelmed to the point of breaking at least a year or 2 ago, some of those services are now referring to social prescribing, and we're hoping to do some research that will look at those relationships, and are there a proportion of people that will benefit from social prescribing and don't actually need those services because you've actually already addressed what it was that needed addressing.
Do you know, it actually sounds like chaplaincy, because that's
Yeah,
what a chaplain does. We
Yeah.
sit with people and we listen.
Yeah.
And we're there when people need someone to talk to, which is the most human of things, is that connection.
Yeah. And I think so social prescribing is a term that's allowed the government to, put it into policies. And, sort of professionals will debate the term. And I often say it doesn't matter what we call it at the end of the day. The point is there's a person who's vulnerable and in need, and they're getting support. And by having a term like this, it's allowed it to be systematized. It's still individual at the face-to-face contact, but it's allowed us to bring together all these sectors and people that are already doing amazing stuff and actually knit it together and putting that human being in the middle. It's redesigning a human back into what's become quite an automated system. And you put a human back in and they spot the things that don't meet a criteria. And you hear the things that make you think, actually, I just need to follow this up. And it wouldn't work if you just had a
Yeah.
criteria to follow.
So how have you brought the healthcare, because they're really slow adopters, as you will know, how have you brought them along so they think this is a good thing? I mean, obviously the first thing they've got to ask, where is the evidence this works? I mean, that's what they want to hear.
Yeah.
But then there's a whole lot of education, so they actually
Yeah.
know about it and they feel
Yeah.
confident in referring.
Yeah, there's been various approaches, Kathie. So there's been the ground up massive swell of people just coming on board and wanting to do this. And then actually we ran a conference 5 years ago, just over 5 years ago, the first conference, and we had no way of knowing who was doing what. And it was a bit of a word of mouth. We kind of heard about a person here and a person there, and they might know somebody. And we thought we'd get about 50 people to come together in a room, and we got 100 and a waiting list. And it felt like we just lifted up this little carpet and there was all this activity underneath, and people had been doing it really quietly because it wasn't really what they were meant to be doing within a very fixed system, and they thought they were the only ones doing it. And what we did in the early days was actually just allow people to understand they're not the only one with that idea. And when everyone got together and realized they were not alone in this way of trying to look at people as human beings and not just, you know, saying you feel depressed, have some medication. The buzz was incredible because everyone was so excited. And I remember someone saying, oh, I thought I knew everyone in my field that was doing this sort of thing, and I've met loads of new people today. So that was one thing, it was connecting the people that are doing it. And then it was understanding what was working for them. So we've done a lot of work that I've never had chance to publish because this has just gone so fast, 0 to full health system and international within 5 years is bonkers. But we did a lot of work on what are the principles that underlie it that are working for people. What does good look like? And we put out a kind of a set of principles. It's like you've got to make this your own in your own area, but the principles underlying it are about that connecting and listening and good simple referral routes and being flexible so we got a whole list of stuff, so we could then give that back to the NHS. And there was a year or two of actually working with them to kind of co-design, and there were some people in the NHS England organisation that were willing to do it a bit differently themselves. And I think they started to acknowledge that something really good was going on here. But if you just say, so for a long time, people kept saying, what's the model? What's the model? Give us a model. We just want a model to push back down. And it's like, if you do a model, just one model, it doesn't work because you kill that individual nature of what people's needs are. But if you have underlying principles, people can then materialize that in the way that works for them with the existing assets that are already in their geographical location. So it's about helping a health service understand what asset-based community development is, and trying to bring people into a shared language. So I used to ban acronyms, because if you just speak in abbreviations and acronyms, everybody gets confused. And then it was about looking at the places where it's already working well and starting to research that a bit more and understand a bit more. And the main thing I suppose people want to hear is there a return on investment in some way? So we were commissioned to write a guide, and we were commissioned, so myself and the Social Prescribing Network steering group, which is made up of people that are commissioners and that are on the front line doing this and have helped pioneer it. So it's an amazing group of people to work with. So we wrote a guide on how to set up social prescribing, really about the principles and how to collect some of the data. And also we looked at the economics of it. So where we could find information on return on investment, we analysed that. So we did a briefing paper for the NHS on the service, sort of the economic impact of health service usage. And the early data was showing you that there's a reduction in people visiting GPs, you know, around 5 to 25% on average. You know, I think it's something like 28% reduction on average. And these are low, it's a low number of studies that are going into that. And there's no clear way of defining social prescribing. So there was a lot of very careful thought with information specialists on how you find the information. And we weren't looking at peer-reviewed published papers all the time, because this is not a field that exists. It's only now we've literally got a fund come out for a national evaluation in England now. Yeah, and actually there's reduction to GPs, there's reduction to A&E, there's reduction to secondary care, there's reduction to unplanned admissions back into hospital where people were leaving. They didn't have the support from the social care and they're getting admitted back. And we, you know, you're walking a tightrope, because you know that you have to be very careful. We're saying this potentially looks really good. And if you had any pharmaceutical product that said, if you prescribe this pharmaceutical product, on average, there's a reduction in visits to A&E, GP, secondary care, unplanned secondary care by this amount, your hand, leg, arm, head would be bitten off, because that would be the most successful pharmaceutical product. And not only is it just for one area, any human being can have it. So actually, when you compare it to what's happening in pharmacy, the economic potential is quite large, because you're treating acute conditions, whether that's a medical condition or acute crisis in someone's life, and you're supporting that. But you also can start to think, what about the prevention angle? What about if we're supporting people to stop smoking? And that really helps, because there's a support mechanism alongside. What if we're supporting people to reduce their weight and get more physically active? That is, you know, that goes into like the top 10 chronic diseases that cost the health service a huge amount of money. I mean, must cost about 10 billion a year for people with diabetes and pre-diabetes. You know, these are phenomenal figures when you start to work at it. Once we started to get to that stage, the next thing that happened was they started to work out how to put a code into the electronic medical record system for primary care. So over the last sort of 2 years, we've been promoting the national recording of this, because you can't do that big scale analysis. Everyone's like, well, they might be small areas, but when you have a lot of small areas producing the same data, there's a point at which you have to say, hold on, we're not seeing massive variation in the outcomes. We're seeing similar outcomes, and these are interesting and good outcomes, and there is return on investment, and there is social return on investment. So now we're at the stage of needing to standardize. GPs need to say that they're referring. We've got digital platforms from companies that can track where people go, so you can do a lot more analysis of how many prescriptions people are having, where they're going. Very interestingly, the evaluations I've been doing, so I still do literally one project on the ground evaluations with organisations, because I like to keep connected. You know, you can look at why people are referred, but why people are then, what they're prescribed and what they need supporting with only matches 50% of the time. So a person referring in is catching a bit of the need, and they're going, actually, I know you're going to need some support, but they don't have the time to unpack why. But if you look at what people are supported with, so we looked at something that had 36,000 prescriptions over a period of time, and then you can break down the categories of why people are having support. And it is, you know, that it is housing, it is work and employment and training and education, and carers need support. And yes, there's some mental health and psychological stuff, but it's basically aspects of a person's life. You know, so now we have the national capture of data, and there's an observatory that has real-time data of who's being prescribed to go to a link worker, and that's getting going as more GPs use the read codes. So now you can start to split that out as to who's using it. You can start to look from an inequalities angle. You can look at age groups. They've started to see how that's changed during the pandemic. And money has started to come. So we've worked behind the scenes to help to understand what are the methods you use. You can't do randomized controlled trials when A, you're rolling a scheme out, and B, it's not a a attribution of cause and effect as you have with a pharmaceutical product. So you need to be looking at effectiveness. We need to understand what to measure first. You need to know what your kind of degrees of change are before you can power up more studies. So we've been doing all of that work across the country. People have been gathering data at a local level. And there's a lot more information to think, well, actually, if there's going to be a national evaluation, and it needs to be mixed methods, and we've got a good idea of what outcomes to capture and maybe some theoretical underpinnings. And we're at that stage now. But actually, nobody needs to be told that we don't need to collect more evidence to say that physical activity is good for you. That's pretty much done. We don't need to collect evidence that says eating fruits and vegetables and reducing your sugar and fat intake and things like that. That's pretty much done. I don't think we need evidence that says if a person's isolated, it's bad for their mental health. And actually by connecting them to organisations, that's positive, because I would say there's a huge evidence base on that. And I don't think we need much evidence now to say that if you compassionately talk to a person, they might reveal what actually is worrying them and you can understand their unmet needs. Because as you say, that this whole idea of chaplaincy has existed for rather a long time, and there's quite a lot of evidence behind that. I don't think we need evidence that says if you support a person to volunteer, be part of an organisation and build their confidence, that it makes them more employable. Because I think that's, again, we understand what employability is because we have loads of training schemes. So I think it's really hard to start saying there isn't evidence for this, because what we're doing is we're connecting from one evidence base to another. So it's you might want to look at the evidence now for how from a rollout and quality improvement perspective is how do you best set up a scheme and how do you best run it, and what are the best things for a link worker to be doing, things like that. So I think this idea of there isn't evidence is because people have traditionally worked within one field, and this is in a sense a new field on its own. So I think that's very different. And actually, as we get national data collected, you can then start to do quite a lot. Reduction in prescribing pharmaceutical products as well as people get more support.
Absolutely. So I guess the takeout that I think is really important, it is an architecture, and once people can understand that, it really helps. And the second thing that you've said is really there is evidence for all the things that a link worker is helping somebody with. And it's, as we've said, it's putting the human back into healthcare, which people are just so busy, or they're conditioned and trained to look at only disease and not look at the whole person, which has really lost its plot. And some of that's due to pharmacies and drug companies and the emphasis on all of that. It's just fascinating. So I just want to pull that together before we move on. If somebody was thinking, okay, well, I think we sort of operate a bit in that area, where would they go to find the principles you've used to perhaps check in and think about their own architecture?
So you could just go to the Social Prescribing Network website. I think it's socialprescribingnetwork.com. We've got a little resources section where you can pull some main stuff off, but actually we just get a lot of people say that I'm in this area or this country, and as people contact us, we keep a note of who's where, and then we say to them, do you want us to link you up with somebody that we already know, or we might have 3 people on our database. So there's a few thousand people in the network, and we're on Twitter at Social Prescribe 2. And there's 7,000 or 8,000 people there. So we just connect people up with permission. So by doing that, we're now establishing a network in the US, and there's a network in the Netherlands, and there's a network growing in Portugal, and there's networks in quite a few countries now. So there are odd people in Australia that we know of that are doing this sort of thing, and I'm sure there's a lot more. So it's just a case of when we hear more people, we just connect up, and actually we just then let people, that organically develops. So that would be that. And if people are interested, we're running an international conference on the 4th and 5th of March, which is all online, and all the talks are pre-recorded, so people will see it live with the Q&A sessions that go with it, but very soon after, and for a month, you can get all that material. So and it's focusing on community and inequalities this year, and we've got speakers from various countries actually as well taking part, from Australia and New Zealand, and yeah, sort of
Wonderful. Okay.
health
Well,
organisations. So really, so there's two places,
Well, I'm going to attend, so therefore you've got an extra conference
excellent.
delegate. And I'll put the link at the end of this conversation if people would
Sure.
like to follow those areas. So you've also got coming up International Social Prescribing Day. Is that correct?
Oh yes.
Tell me
18th
about
of
that.
March. Yeah, so this was, you're saying, how do we sort of bring people along with us? One of the conferences that we ran, I think 3 years ago, a medical student stood up and said, I really buy into this, but when I talk to my consultants, they just basically dismiss me. And so that's Bogdan Chiva-Gyurka, and he has now put together a medical student network. So what he did is just an incredibly enthusiastic, passionate doer. So I was like, if you want to put a network together, that's great. And it's kind of a collaborative with NHS England and a network. So they now have students in every medical school across the UK that are peer-to-peer teaching each other about this, and now they're getting social prescribing brought into the medical curriculum. And it was his idea to start he started a social prescribing day a couple of years ago, and it was really for people for the medical students really to sort of be for a day telling everyone about social prescribing. And we had various organisations did events around the country and leaflets and all of that, and people just really enjoyed the fact. So last year we had International Social Prescribing Day, because actually we're just growing outwards in a lovely way. So it is this year, instead of us having lots of events that we can really do, it's really a sharing stories of how social prescribing has helped people, particularly in response to the pandemic. So in this country, social prescribing has been a massive part of our national response. And it's really just to share that on social media, just sharing that information. So it's just a day to celebrate social prescribing.
Okay.
We spend all the other days working on it, and we have a day just to hear and celebrate and, respect everyone that's doing it. And
you'll love this, Marie. When the pandemic first broke out, I mean, everyone was scrambling to organise services. And we thought, what can we do? Well, and it's now cropped up everywhere. But we established Chat with the Chaplain, and we did it virtually. And in the first 3 weeks, while everyone was scrambling, because it's what we do, day in, day out.
You already know the people.
We had 15,000 calls, and we had, and it was going 24/7. We had chaplains from everywhere, all faiths, those with no faith, because people were frightened and they were lonely and they were isolated, and they just wanted somebody to talk to. They didn't, they weren't suicidal. They didn't need to get mental health support. It was genuine. They just wanted somebody to listen. So, I mean, that's probably a really good example of how we can bring the human back into connecting.
Yeah, absolutely. It's just, I think we've forgotten the power of humans connecting in a way, and maybe a lot of people now, it's very at the front of their mind, because for us, we've been in lockdown off and on for quite a long time. I haven't seen my parents for nearly a year, and I haven't seen hardly any of my friends. We can't connect at all. And I just think that connection, we can connect virtually, but there's days when, you get a bit fatigued of connecting virtually. And just to remember that there's incredible power in two people coming together in a respectful way. And when somebody is in a vulnerable position and compassion and love and kindness is extended to them, it is transformational in a way that we can't do with much medical products.
True.
And actually the research I did with people with cancer, when we said, what's been important about this service? And they could say anything, and they could say something positive or negative. Consistently, we heard it's the care, the kindness, the love, the support, being with others, and we sort of published all that work. And it's those basic human qualities, isn't it? That yes, you want the biomedicine because that's you probably can't get better without it, or you can't maintain a situation. But to go alongside that, you also need the care, the kindness, the love, the support. Not there's nothing more we can do for you, shut down all hope in your life, but actually let's see how we can support you, because there's always something you can do, even if it's just sitting, talking and listening. Not everyone's going to get better. That's our cycle of life, isn't it? And we have to accept that, but you can always compassionately support and listen. I always think it's like dropping a stone in a pond, and it has the ripple effect, and we don't see, as people that are there with a person, listening and supporting, or praying, or whatever, we don't really see what happens when that conversation ends and they go away. And sometimes you hear back and someone say, oh, I'm so grateful for that, because, but we just have to have that faith in the fact that those ripples are always happening, and the more people that you're getting those ripple effects with, the better, really, I think.
Absolutely. So that sort of brings us to a sort of a beautiful ending towards this. Obviously, this is really full on for you, and I've been, we've been chatting privately about what your life's like in lockdown. How do you look after yourself? What do you do to practice self-care?
Yeah, so because I'm a Reiki master, I can do Reiki on myself anytime, which is really good. Um, and just being able to go to bed and just give myself Reiki is really important, particularly for my mental state sometimes. We go out for a walk every day, and we make sure we go somewhere that's green. And kids and I, we get out, and we go with our phones and take some photos of the nature as it's changing. And it's very wet and muddy at the moment. It's sunny today, but we've had lots of rain, so you slide along at the moment rather than walking. And yeah, we do that really, and just look after what we're eating. We just try to, we're at home, I cook everything, and just maintain a really healthy diet. And that's a far cry from getting our 1974 camper van out and going camping around the country and kayaking and surfing and all the stuff we were doing, and going out with, into the countryside with friends. That's pre-COVID life. We did kayak when we were allowed out, when we weren't completely locked down, and that's fantastic, just going up and down the rivers and stuff. And so yeah, that's as far as we get these days, but it's keeping us going.
Good. And you've alluded to it. What does spirituality mean to you? I ask everyone this as the last question, and it's such a big subject. It means different things to different people.
I think spirituality has meant different things to me in my life. I think that deeper connection with something. I think when I was younger, I always felt there's a connection with an energy or something, and particularly with practicing Reiki, there's such a deep calmness that you as a practitioner receive when you're channeling energy, and the calmness that your client, person you're treating, receives is really amazing. And I always feel fantastic and peaceful. So that deep peace inside your heart when you know that what you're doing is the thing that you're meant to be doing, and you're on the right track. And then as I've got older and my faith has grown, and I'm now a lay leader of worship, spirituality to me is my connection with God. And for me, a lot of the decisions I made in the last 5 years are decisions that were made about social prescribing, and how to take it into a system. And maybe we didn't want to always do that, because you're worried that actually what you've got will just get morphed into a model and shoved down, and it's not going to work, you'll kill it. All of those decisions were done with a lot of prayer behind them for me, and a lot of thought, and and there were times when it was a bit of a truth to power situation, when I would say I'm not going to do it if it's like that, because I don't believe that will work. And decisions where you think, have I just said something that's going to kill my career? But I feel that I have to really listen quite carefully to the guidance I'm getting and do what I think is right. So a lot of what we're bringing in is, for me, what I would read in the Bible about Jesus, and Jesus never left anyone out. And everybody was showing compassion, and everybody was welcome. And for me, that's the basis of what we do. But I don't tell people it's Jesus into the NHS, because I think they'd freak if I say things like that. But for my own journey, that's taken me well away from what I was doing, it's been such a learning curve. But a huge amount of prayer, and I go to church each Sunday with a massive conundrum in my head, and someone would preach. For an example, we're getting to the stage where I think this was about to go into the system, and I was just concerned that it might all go pear-shaped. And one of the preachers was talking about something and said, there's a fork in a road and you've got to take it. And when you hear those things, it's like, wow, that really chimed. And I thought, yeah, we're at a fork in the road, and you have to let go, and you have to just accept that's the route that is unknown. We don't know where the next step is. I don't know what's ahead. But for me, that spirituality has given me the faith to just say, okay, we'll make that next step. And I trust that there'll be something under my foot when I make that step. And I trust that way will open up, but I can't see it at the moment. This is just, this is way out of what it left the comfort zone a long time ago.
Well, I've got to say, Marie, thanks so much for talking to us. It's been I could talk to you forever. We're like kindred spirits with what we actually do. Let's come back and talk again. We'll certainly be supporting you for International Social Prescribing Day, and we'll attend your conference and spread the word. And I'll encourage people to check out your website and go to the conference. Thanks so much.
Thank you, Kathie. Take care.
Take care.